It will be my pleasure to present on the latest approaches to pulmonary hypertension. And I think Dr. Sharma is right. Compared to the other topics that were discussed previously, pulmonary hypertension remains, I think, still a niche field. So a lot of people refer to as patients for management, but I think it is important to understand where we are with the management of this disease and what are the things that are important in terms of deciding which therapy to give to the patients. So over the next 20 minutes or so, my objective will be to review basic diagnostic criteria of pulmonary hypertension, and this is a key element because we actually need to provide information about the right heart cath when we request therapies for patients, provide you with some risk stratification tools that you can use in your daily practice to have an idea of where the patient is in terms of risk profile, and go over some therapeutic options for PH, including novel disease-modifying therapy, and go over a quick case just to give you a sense of the complexity sometimes we are facing with the approach to this condition. So to start, I think it is fundamental to begin by going over the hemodynamic criteria of pulmonary hypertension, because as I was mentioning earlier, this is something we actually need to provide when we request approval for therapy. And the guidelines have changed over the years. So what do we define as pulmonary hypertension? By definition, pulmonary hypertension is any mean pulmonary arterial pressure greater than 20. And by the way, this slide was taken from the latest ESC guidelines, which were published in 2022, which are the leading guidelines that we use for managing these patients. So again, mean pulmonary arterial pressure greater than 20. And then once we have a patient with this, again, meets this criteria, we need to distinguish whether or not the patient has isolated precapillary pulmonary hypertension or isolated postcapillary pulmonary hypertension, and whether or not there is a combination of precapillary and postcapillary. And it is important to know that because, again, we have specific therapies that go with each of the specific conditions. So we talk about precapillary pulmonary hypertension anytime we have a mean pulmonary arterial pressure greater than 20, but the wedge, by definition, has to be less or equal than 15. And then we want to see a PVR greater than 2. We talk about isolated postcapillary pulmonary hypertension anytime we have a mean pulmonary arterial pressure that is greater than 20, but the wedge is more than 15, and the PVR typically is less than 2. We talk about a combination of precapillary and postcapillary with comorbidities usually. Anytime the mean pulmonary arterial pressure is greater than 20, but the wedge is more than 15, and the PVR is more than 2. And in the latest sort of guidelines that were published in 2022, they also reintroduced the concept of exercise-induced pulmonary hypertension, which had disappeared from the guidelines in 2015. And now they define exercise-induced PH based on the slope of the changes in mean PA pressure and cardiac output at rest and with exercise. Having said that, even though we know how to define exercise-induced PH, still we have no targeted therapy for this condition. So it's hard to know exactly what to do with these patients that have this isolated form of PH, aside from monitoring them closely. As just to review quickly, the guidelines that were recently published updated the definition that we used to use up to 2022, essentially, where pH was defined as a mean pulmonary arterial pressure of greater than 25. So we went from a mean pulmonary arterial pressure of 25 to 20. And the reason why that was done is because in looking at the average population, the mean PA pressure tends to be around 15. So it was always felt that 25 was too high. So they lowered the cutoff from 25 to 20. In addition, the new guidelines have removed what we used to adopt to distinguish isolated postcapillary from combined postcapillary and precapillary pulmonary hypertension, which is the DPG. So previously, we used the DPG to distinguish patients that had isolated postcapillary pulmonary hypertension, essentially pulmonary hypertension due to left-sided heart disease, from the patients that had a combination of arterial and venous pulmonary hypertension or precapillary and postcapillary based on the DPG, which is a diastolic pressure gradient. And we used to indicate that actually in our requisition for the medication, but right now with the new guidelines, we don't do that anymore. In addition to distinguishing patients based on hemodynamic criteria, we also classify patients based on etiology, and we have 5 different groups of patients. So every time, again, we care for a patient, we need to sort of know where it belongs, whether it belongs to a group 1, 2, 3, 4, and 5. And the reason to do that is primarily because we have specific therapy essentially for each one of the conditions. So the classic form of pulmonary arterial hypertension, which is associated to vascular remodeling that you can see here, is called group 1 pulmonary arterial hypertension. And you can see this form of arterial disease in the artery of the lung in patients that have idiopathic, meaning, again, as you all know, we can find a cause for the disease, or they have a gene, they've inherited a gene that causes the disease, or they have pulmonary arterial hypertension associated to conditions such as connective tissue disease very often, or congenital heart disease. The most common form of congenital heart disease that lead to group 1 PAH are a PDA or an ASD and a VSD. And then we have the group 2 form of pulmonary hypertension, or associated to left heart disease. And you can see here that in this category we have the isolated postcapillary, where, again, the wedge is more than 15, but the PVR is less than 2, and the combined pre- and postcapillary form of pulmonary hypertension, where we have a mean PA pressure that is greater than 20, but a PVR that is greater than 2. And it is important, again, distinguish these 2 categories, because while we typically don't know what to do, or we treat with heart failure therapy patients that have isolated pulmonary, left-sided, postcapillary pulmonary hypertension with heart failure medication. Sometimes we treat with pulmonary specific therapy, vasodilatory therapy, patients that have a combination of pre- and postcapillary pulmonary hypertension. And then we have group 3 of PH associated to lung disease. Typically, this form of PH tends to be non-severe, but there are cases where it's very severe, and people actually need to be treated similarly to patients with idiopathic or group 1 pulmonary hypertension. Group 4 is a condition that is probably very underdiagnosed. It's called chronic thromboembolic pulmonary hypertension, and is associated to recurrent, or we believe, repeated pulmonary emboli, leading then to vascular remodeling. And then we have this mixed bag of group 5, where we essentially have a number of different conditions that can lead to pulmonary vascular disease. At the bottom, you can see the different prevalence. So the most common one is group 2 pulmonary hypertension, followed by the group 3 form of pulmonary hypertension and all the other forms. So the traditional form of pulmonary arterial hypertension, which is the group 1, is actually quite rare. And if you look at the entire spectrum of the population, and you take all comer, actually pulmonary hypertension in itself, regardless of the group, is a very prevalent condition, affects up to 1% of the general population. The basic workup you're very familiar with obviously involves doing an echo, doing a CT, to exclude chronic thromboembolic disease. Clearly, radar CAT is a key. VQ scan is something we have to do even though the CT is negative, because it has a higher sensitivity compared to the CT, and lots of blood testing to exclude, for example, connective tissue disease, HIV, or liver disease, other conditions that might be related to PH. And very recently, we've also been doing a lot of genetic testing to exclude genetic form of PH. So I tend to now incorporate that pretty regularly in my assessment. So again, group 1, so just quickly, we have genetic form that I mentioned, BMP mutation, ALK1 mutation, and I'll go back to that again at the end when we talk about some disease-modifying therapy. We have the form associated to connective tissue disease. Those are the ends. This is a pictorial of a patient with scleroderma or a patient with lupus. I tend to see many of these rheumatological cases in my clinic, or HIV, liver disease, congenital disease with clubbing, and commonly is ASD and VSD, and drug and toxin. It's not as common, group 1 PH associated to drug and toxin, at least for what I can see, but I know there are some parts of the country, especially in Arizona, and I think primarily Arizona, where it's very highly prevalent to have this form of pulmonary hypertension associated to drug and toxin. Left-sided heart disease, again, very prevalent. It is estimated that up to 50% of patients with heart failure, preserved ejection fraction, have pulmonary hypertension, which by definition is due to left-sided heart disease, so the wedge tends to be high in this patient. And it is present in up to 70% of patients with severe symptomatic mitral disease and up to 50% of patients with symptomatic aortic stenosis. And it's overall the most prevalent form of the disease. And among the different causes you can think of is obviously untreated hypertension, ischemia, and all forms of valvular disease. They tend to essentially lead to left ventricular dysfunction and as a result of that, elevation in wedge pressure and elevation in pulmonary pressure. Obviously, heart failure with preserved ejection fraction falls into this category, and it's often associated to pulmonary hypertension. The form that we see with lung disease, again, tends to be usually not very severe. Typically, it's, the mean pulmonary arterial pressure is around 35 to 40. Besides COPD, which includes obviously emphysema and COPD, and bronchitis. We also have some form of group 3 pulmonary hypertension that we see with the interstitial lung disease or hypoventilation syndrome. And I wanted to take a moment right now to say that one of the reasons why we actually have to do these classifications and to group patients into different categories is, first of all, because it helps us with clinical trial designs, and second of all, because we don't have a way of actually looking at pathology in this patient. We don't do biopsy of the lung, so we don't know exactly what is the situation in the vasculature of the lung. And I'm saying that because there is actually histologically an overlap between patients that have group 3 disease in terms of arterial vascular remodeling compared to group 1. But again, it's not something that in clinic we do. The only thing we can say is associated certain diagnosis with a certain anticipated form of pulmonary hypertension. So, group 4 is anytime we have chronic thromboembolic pulmonary hypertension. So it's the speculation is that those clots that migrate to the lung obviously lead to vascular remodeling to the point that there is formation of this thick material that lines the vasculature. And it is actually the only form of pulmonary hypertension where there is a surgical approach. And the surgeon, what he would do if there is involvement of the proximal part of the pulmonary tree, would go in and slide off this material, removing the obstruction and technically fixing the pulmonary hypertension. It is much more complicated if the obstruction involves the more distal vessel, in which case what is being proposed right now is to do balloon pulmonary angioplasty, essentially. Some centers are very skilled at that, and they perform quite a few of these balloon pulmonary angioplasty, especially for this distal disease that would not be amenable to surgical intervention. And then we have, obviously, the very distal disease where surgical approach is not possible. And group 5 is a miscellaneous combination of various different conditions that leads to PH, such as sickle cell disease, sarcoidosis, and end-stage renal disease. And again, we don't look at the vasculature, so we don't necessarily know which patient has which form of disease, but typically they're considered the arterial form of pulmonary vascular disease, including end-stage renal disease. So aside from diagnosing PH and obviously knowing which category the patients belong to, we also have to risk stratify the patient to have an idea of the aggressiveness of the therapy. And most of the slides that I will show are taken from the latest guideline published in 2022. And the way we risk stratify is by taking in consideration a number of factors and then dividing patient into low, intermediate, and high risk profile. And the objective of initiating therapy is essentially to move people or patients across category of risk. So if we see a patient that falls into intermediate risk, our objective starting therapy is to move him from the category of intermediate risk to the category of low risk. And again, all the factors that we take into consideration include the symptoms of the patient, whether or not there's been a history of syncope, how far they can walk. 6-minute walk test is a thing in pulmonary hypertension we use very much. or the functional class. We can also do more advanced testing, such as CPET. We can do echocardiography, cardiac MRI, and hemodynamic. And the other thing that is very easily done in clinic is to check the BNP level. And we really follow the BNP level very closely in the pulmonary hypertension literature, and it's somewhat different than heart failure. Obviously, in heart failure, we do monitor the BNP, but for us, it's actually a very important determinant of, again, therapy escalation. And you can see that the cutoff that we use to determine normalcy, to define somebody as having a low risk, is much actually lower than normal. Actually, to be in a low-risk category, for the BNP level alone, the value has to be less than 50, which is typically much lower than normal value, which is around 100, at least for our standard measurement. So again, BNP is probably the things, in addition to functional status of the patient, that I use the most in my clinic, and it really helps with risk stratification and decision to treatment. And because there was a concern that the 3-risk approach was actually somewhat mixing patients in the intermediate risk, and wasn't as accurate in distinguishing those that were low, intermediate low from intermediate high, the newer guideline also incorporated the 4-risk strata assessment, which you can see is a little bit more refined and use a point scoring system. But again, the variable that I use are functional class, 6-minute walk testing, and BNP or NT-proBNP, and all things that you can do in clinic, essentially, to decide whether your patient falls into a low, intermediate, or high-risk category. And the other risk score that we can use is called the REVEAL risk score. Was published by Dr. Benza's group, and it looks at the REVEAL registry, and it takes into consideration a variety of factors, and then comes up with the score. And again, the score just defines patient into belonging to a low, intermediate, or high-risk category. And important to also underline the fact that even though we do all this risk assessment and we know where the patient is in terms of the status of his disease, very often there are a lot of limitations to actually reaching the target, which is the low risk. And those limitations are because the patient is not compliant, or the patient cannot tolerate the therapies. The therapies can have a lot of side effects. Or there is an issue with cost. Very often, I have to say, cost becomes less of a concern because all the major companies have actually a very good patient assistance program. So let's move on to therapy. I think with the appearance of the new disease-modifying agents, I think what we now are doing is dividing, our approach to pulmonary hypertension in old approach versus new approach. And the old approach is essentially based on the use of agents that are primarily vasodilator. They target the endothelin pathway. And in this category, you might be familiar with bosentan, ambrisentan, and macitentan. There are the 3 drugs that we typically use. Bosentan is falling off sort of favor because it actually it's a medication that you need to take twice a day, and it does require actually liver monitoring of liver enzyme, which is not the case for ambrisentan and macitentan. Then we have the nitric oxide pathway that we target again, the main mechanism of action being vasodilation. But we know that they also have other action on the vasculature, but primarily vasodilation. This category includes tadalafil, sildenafil, and riociguat. Riociguat is considered stronger compared to tadalafil and sildenafil because it acts directly on the guanylate cyclase, so it's not subject to tachyphylaxis. And I'm saying that because sometimes people that have been on tadalafil and sildenafil, if they don't reach their goal or their targets, are switched to riociguat, and they find that this change, even though the drug belongs to the same class, makes a difference in the functional status. And then we have the prostacyclin, which include the remodulin, and we have different form of remodulin. Remodulin can in fact be administered IV, sub-Q, or in an inhalation form. The inhalation form is called Tyvaso. Flolan and Beletri are the epoprostenol, and they are essentially 2 different variants of the same drug. And then we have selexipag and orenitram, which are the oral version of the prostacyclin. Orenitram is essentially a remodulin oral. Selexipag is a different drug that acts again on the prostacyclin pathway. The novel agent that is being introduced in the market a few months ago is called sotatercept, and compared to the old agent, is a disease-modifying agent, meaning it's supposed to modify the vascular remodeling within the lung structure. It is an antibody that targets the activinin, and in binding the activinin, it changes the balance between anti-proliferative and pro-proliferative mechanism within the lung vasculature, and is expected to really modify the substrate within the lung. So this is the new agent that we started to use essentially a few months ago. How do we escalate therapy? Again, it's all based on risk assessment, and the first thing we do is to look at all these criteria that I showed you earlier in terms of patient symptoms, functional class, NT-proBNP, BNP, echo, and based on that, distinguish the patient into a low, intermediate, or high risk. If the patient is low intermediate risk, might be enough to just start with oral therapy with an ERA, endothelin receptor antagonist, and a PDE5, sildenafil or tadalafil. This is called actually for the audience, the AMBITION protocol, because it was studied as an upfront combination therapy in the AMBITION trial. If they are high risk, typically then you would want to consider going directly to the prostacyclin. Either oral or IV, sub-Q, or inhaled. And then you redo an assessment of the patient after a few weeks, depending on the severity, and based on how the patient has responded at the reassessment, you decide whether you can continue on the current therapy or you need to escalate. So what the guidelines recommend is close, essentially, monitoring of this patient to decide whether or not they're really moving across category of risk or remaining into a high-risk category. And a few of the key paper and highlights about therapy for PAH. I would say this in the group 1 category is the seminal paper that was published in 1996. It was conducted out of Columbia by Robin Barst, and it is the first study where they actually looked at the use of prostacyclin in group 1 pulmonary arterial hypertension. And it's the first study that up to today has shown an improvement in survival in patients with pulmonary arterial hypertension. So we consider that our seminal study, and nobody has replicated to that extent, because right now it was conducted against placebo, and we cannot obviously do a placebo-controlled trial given that we have prostacyclin available. This is instead in the group 1 population, the study that was just published in 2023 on sotatercept, which is the new disease-modifying agent to treat patients with pulmonary arterial hypertension. And in this phase 3 trial, which was a follow-up on the prior study, which was a phase 2 and was called, not the Stellar, anyway, so this is the study. The prior one was a phase 2. So they randomized patients to receive sotatercept versus placebo on background medical therapy. They had approximately 160 patients in each of the group, and duration of treatment was approximately 24 weeks. And all patients that were included at the group 1 pulmonary arterial hypertension, that was classified as idiopathic, irritable, related to drug and toxin, or connective tissue disease, or congenital heart disease, but they had to add repair shunt. So there were many different forms that were not necessarily included and definitely not group 3, definitely not group 4, so it was all targeting group 1 patients. And they had functional class 2 to 3, and most of them were already on triple therapy, and 40% of those were on parenteral therapy. And what they noticed was that essentially at the end of the trial, they were able to see in patients that were treated with sotatercept up to 84% reduction in mortality. There were, however, some side effects from from the sotatercept use that included epistaxis and telangiectasia, as well as an increase in hemoglobin level. In fact, one of the things that we need to do when we initiate this therapy is to monitor the hemoglobin and ensure that it doesn't go above a certain cutoff. The issue of telangiectasia is something that is concerning to the PH treating physician, and it has to do with the fact that this antibody are targeting a pathway that has been linked to another condition which leads to PAH, which is called hereditary hemorrhagic telangiectasia. So our fear is that the use of this therapy long-term could cause development of more telangiectasia and the patient could develop a form of PH similar to patients that have HHT. Again, it's all to be seen. The study was conducted over 24 weeks. There is an open label extension, which is still ongoing, and it seems that even at 2 years, the benefit of sotatercept is maintained. So we have started using this medication since June of this year, and we'll have more information on real life patients soon. And quickly going over other seminal study in group 2, this was a study which was paradoxically called the first study, and it was also the last, looking at the use of epoprostenol in group 2 patients. Despite the fact that in this patient population, treatment with epoprostenol resulted in improvement in some parameters like cardiac index, reduction in PVR, it seemed that the outcomes were not as good, so the study had to be terminated early. And following this bad experience with the use of prostacyclin in group 2, there weren't really other attempts at studying this group 2 population. So there has been a few studies in group 2, but none that has really changed our approach to this form of disease, which is primarily, for now, targeting left ventricular dysfunction. Just pointing out that because there isn't a lot of data regarding group 2 patients, what the guidelines say is that when you have actually somebody that has what we call out of proportion to group 2 pulmonary hypertension, meaning there is very high PVR, even though the wedge is elevated in this patient population, you might consider using parenteral therapy or other therapy that we normally use for group 1, because there is really lack of evidence. Moving quickly in group 3, there are 2 seminal studies that were done, one using inhaled treprostinil, which is the inhaled version of Remodulin in patients with interstitial lung disease. It was a positive study. So it showed an improvement in actually walk distance that these patients were able to perform. So we now use in group 3 patient Tyvaso. Interestingly, and I was involved in this other study, when we did the same thing but in COPD as opposed to ILD, what we did see is that actually patients that were received inhaled treprostinil compared to the ILD population had the worst outcome. We don't really know exactly why the study was terminated early, because there was higher mortality in patients that were receiving inhaled treprostinil and had COPD. I've had some of those mortality, and the feeling that all of us participating was at the end is that one of the major problems with the COPD population, which is different from the ILD population, is the number of comorbidities. So many of these patients have a lot of comorbidities. They've been heavy smoker in the past. They have coronary artery disease. They have a lot of diseases that were not necessarily represented in the ILD population. And lastly, and then I conclude, the calcium channel blocker. We have been using at the beginning calcium channel blocker to treat patients with pulmonary hypertension. To start this therapy, you need to demonstrate that the patient is responder to vasodilator challenge. And to do that, typically you give some inhaled nitric oxide in the cath lab, and you look for a reduction in the mean pulmonary arterial pressure. And by definition, this reduction is to be greater than 10 to a mean PA pressure of less than 40. So if the patient is responder, then you can consider giving calcium channel blocker. but the dose that we give are much higher. You can see, amlodipine, for example, up to 30 milligram per day. And what the guidelines say is that if you consider giving a calcium channel blocker, then it is important that you assess patients from the point of view of the risk profile and consider adding on the other therapy if you don't reach your goal. Quickly over a case, which I think is interesting, and it brings upon some of the issues that we are now facing with the novel therapy. This is a patient of mine, 55, with a history of atrial septal repair and paroxysmal atrial fibrillation. That had a diagnosis of PH in 2002. She was initially started on sildenafil and was lost to follow-up, which is not infrequent because a lot of time when patients have a repair of an atrial septal defect, then this is considered a curative procedure, and very often patients don't follow up with providers. So this patient was actually lost to follow-up and then presented in 2018 in acute and decompensated heart failure. And at that point, she was in a high-risk profile category. I started her on Remodulin and titrated up to 70 nanograms per kilo. And then added on to do triple therapy and combination therapy and endothelin receptor antagonist, as well as I switched her from the sildenafil to the riociguat, which is considered much more powerful and stronger agent compared to sildenafil. With this change, the patient now is doing well, is functional class 2, but the RV remains moderately dysfunctional. So the question that I think I'm still struggling to answer is whether at this point I need to increase the dose of Remodulin, because technically you have to look at Remodulin as essentially insulin. There is no limit, upper limit that we can use. We can go as high as the patient can tolerate. So I know the patient is in the intermediate risk category, so at this point I don't know whether I should go up on the Remodulin, maybe start sotatercept, do both at the same time, or just wait and see what happens. The patient is only 55, so she will need to be on whatever therapy I decide for a long period of time. So I don't know whether we have the answer to this question. I probably would consider studying sotatercept, but I would be very concerned about her being on this medication for 5, 10, 15 years. So I don't know whether maybe the best option would be to do a combination of Remodulin and sotatercept. And with that, I conclude, and thank you very much.